AZCCC presents the Cancer Care Podcast. Arizona Center for Cancer Care. Comprehensive care with the highest quality of cancer treatment in Arizona. Joining us today, breast surgeon and specialist, Dr. Noemi Sigalove.
So welcome.
Thank you.
Well, let's get going. Many women are skipping their annual mammogram this year, and even their treatments due to COVID, thinking they can just do it next year. What are your thoughts and what advice do you give?
When I think about COVID, obviously it is a scary situation for most people. And I think that in the very beginning, when we really didn't know how to handle COVID well, in terms of what we do in our practices or at the mammography centers, I think it was a good idea to shut things down for a period of time until we figured it out. During that time, not to go and get your mammogram was a wise decision, but since then we've come a long way. And most centers, including our own center at AZCCC and most of the mammography centers, have figured out how to safely perform these procedures with really minimal amount of risk for patients. We have figured out how to wear masks, how to do appropriate distancing, how to sterilize things. And I really think that at this point, nobody should be delaying their mammography. I think it is very safe to go ahead and get every screening exam that is necessary.
So what are the different kinds of tests for examining breasts, and when do you use one over the other?
The three main kinds of tests that we have are mammography, ultrasound, and MRI. It is recommended that most women obtain mammograms, and there's different recommendations by different societies. Personally, I go by the recommendation of the American Society of Breast Surgeons, who has taken into consideration many different advantages and disadvantages of modalities and ages at which you should be starting a mammography, for example. So the American Society of Breast Surgeons recommends that women at about age 25 undergo a risk assessment by their primary care physician. And if they have an average risk, then they should start mammography at the age of 40. And if they are deemed to be at higher risk, there are other modalities which are specific to whichever way their risk status is sending them. However, at age 40, mammography is recommended annually until a person has less than 10-year life expectancy. So people always say, what time should I start? What time should I end? So for mammography, start at age 40 annually and stop when you have less than 10 years of life expectancy. The other modalities are ultrasound and MRI. Ultrasound looks at a different thing than mammography does. Mammography is an image that's black and white based on the density of the breast, may give you a very good picture or a very bad picture. Sometimes when a woman's breast is very dense, and this happens in younger women more frequently than older women, it is very hard to interpret that mammogram because you see all white. The components of the breast that are really the working parts of the breast, like the lobules and the ducts and the components that hold up the breast, are the ones that appear as white. So if somebody has, for example, a dense breast, which has those great working components, you're not really going to be able to see very much on that mammogram. And so in those women, it is beneficial to also do an ultrasound of the breast, because the ultrasound looks inside using sound waves instead of using radiation, and it defines those things that you may not see on a mammogram differently. MRIs are even one step further. MRIs are extremely sensitive for detecting abnormalities of the breast, especially breast cancer. They require the least amount of cells to be present in cancer of all those modalities to be able to be seen or appreciated as something abnormal. The problem with MRI sometimes is that they see too much, and then we end up doing additional tests or we end up doing biopsies that are not necessarily desirable. However, the American Society of Breast Surgeons recommends that those women who have extremely dense breasts, where you can't see anything on a mammogram, that really the best way to sort that out is to get an MRI of the breast.
What does breast density mean on a report, and what does the risk score mean on a report? And what are BI-RADS categories?
So these are all parts of a normal mammography report. every woman gets a breast density score, and it goes A, B, C, and D. A means that somebody's breast is almost entirely fatty. So when you look at the image, you see a lot of dark, and that is a radiologist's dream, because if anything arises, it's kind of like, oh, there it is. It just arose and I know what to do with it. I know what this is. B is a little bit more dense, to where there is some tissue that you can see that's denser, but it's still a pretty good numerical value, and we don't really do much with that. C is heterogeneously dense. And so what that means is now we're starting to see a lot more dense breast tissue. Those are the components of the breast that are the ducts, the lobules that create milk, the ducts that bring milk towards the nipple, and then the things that hold up these elements of the breast. And when there seems to be a lot of these components, that mammogram starts to be much more difficult to interpret. And so category C, we start to consider whether or not we want to do additional imaging like ultrasounds to define what we see on that mammogram better. A D is really the worst density score that you can get. It's an extremely dense breast. And what that means is that when the radiologist looks at this image, they are absolutely not confident that they would be able to tell that there's something wrong. And so in those patients who have an extremely dense breast, we recommend that they get what we call supplemental imaging. And so whenever you see that category on your report, extremely dense breast, that means that should be a little warning sign saying, hey, I should have either an MRI of the breast to define better what's going on, or I should at least have an ultrasound of the breast. So that's one component. The second component is BI-RADS category. And there are 5 BI-RADS categories, and every single report gets a BI-RADS category associated with it. It goes from 0 to 5. A BI-RADS category 0 means that we know that something is going on that is not normal, and we need additional imaging to define what that is. So when you get a BI-RADS category 0, your doctor who ordered the test is going to get a letter from the imaging center saying, hey, we see something we're not sure about. So we want to see this patient back again, because we want to do either what are called compression magnification views, which is really a much more detailed mammogram where we give a breast much more compression so that we can figure out a particular area that we're concerned about, or an ultrasound of the breast. And then you get another category that we're going to be acting on after that 0, once it's defined what that unusual part was that they saw. A BI-RADS category 1 means there's no focal lesions, meaning we don't see anything in that breast that is concerning. A BI-RADS category 2 means that there is a benign finding. So the radiologist may see a simple cyst, or they may see something that they definitely know is a benign issue, such as a fibroadenoma, or they may see calcifications that are nice and chunky, and they say, oh, we're not concerned about this. We know that this is milk of calcium. A BI-RADS category 3 is defined as a probably benign lesion. And so in this case, they say, oh yeah, this looks like a fibroadenoma, but just to be sure, what we're going to do is we're going to bring you back in 6 months, and we're going to take a look at it again, because we just want to make sure that it's definitely something that we're not really concerned about. Now, a BI-RADS category 4 is where things start to get a little bit tricky. Because now what this means is that a radiologist looks at an image and says, what I see here, I'm not really so sure I like it, and it might potentially have malignancy associated with it, and I think that we need tissue to make certain that it's not a cancer. And so whenever somebody has a BI-RADS category 4, they will recommend a biopsy. A BI-RADS category 5 means that the radiologist is almost certain that it is cancer, and also a biopsy will be recommended. As far as the risk score is concerned, that is the third item that you may see on your report. And it will be a reading such as your calculated risk for breast cancer is X, Y, and Z. And the only important calculated risk for breast cancer is if that number is greater than 20%. The way that most radiology centers arrive to that number is based largely on your family history, your age, your hormone status. And when that risk is calculated at greater than 20%, then you are considered to be high risk for breast cancer. So that high risk for breast cancer will qualify you for additional studies such as MRI. And that's something that really needs to be investigated further, either with a high-risk specialist or with your primary care physician, because there are models that will calculate that risk even more accurately than that one that you get at the breast center.
So if there's a BI-RAD category 4 and a biopsy is recommended, what are the next steps?
Step number 1, do not panic. And I cannot stress this enough for anyone who needs a biopsy. Because just because you need a biopsy does not necessarily mean that it's cancer. In fact, 90% of the biopsies that we do end up being not cancer. So you have a really good chance that it's not going to be cancer. However, if a biopsy is recommended, then we got to take a look at what kind of biopsy is it going to be. And there's 3 main types of biopsies. The first biopsy is called an ultrasound-guided biopsy. So what that means is that they saw something on your mammogram, we now did an ultrasound, and we're able to correlate what we saw on that mammogram with the ultrasound, and now an ultrasound-guided biopsy is recommended. That can be done either by the radiologist or by the breast surgeon. An ultrasound-guided biopsy will take little pieces of breast tissue out of whatever they see, and we're going to leave a small marker at the site where the biopsy was performed. So in case we need to get back to it, we can, or in case you have another mammogram in 6 months or a year, somebody can say, hey, that little lesion was biopsied, let's pay more attention to it in the future. If, let's say, you have something on the mammogram that we cannot define on the ultrasound, but we can see it on a mammogram, then a stereotactic biopsy is recommended. And that is usually done at the radiology department using the mammogram machine because we can't see it any other way. So the breast is compressed and there's a needle placed after getting local anesthetic into the breast. And again, little pieces of breast tissue that are taken out will be examined and they're going to tell us what that diagnosis is. The third kind of biopsy, which we generally don't really love to do, is the MRI-guided biopsy because it's a little bit more difficult and time-consuming. So if you can get away without having to have that, it's better. But if you can't, sometimes you cannot identify what you see on an MRI, either on a mammogram or an ultrasound, then we do the more complicated type of biopsy using the MRI machine.
So the results show that a patient has cancer. What's next?
One of the least favorite things that I like to do is to tell my patients that they have cancer, but I am a cancer doctor and it has to be done. There is really no good way to convey that information to anyone. So throughout many years of experience, we have found that calling a patient with that diagnosis of cancer is really the best way of handling it, because once you say the C word, people tend not to hear anything else beyond it. But what's important to know that the C word doesn't mean that there's no hope. That C word will be followed up with a lengthy conversation about what that cancer means. Cancer is complicated, and there's many, many different types of breast cancer, and there's many different types of treatment for breast cancer. And it's very important to know that those things will be discussed with you once you get that diagnosis in great detail through a consultation that can last 45 minutes to an hour, and we will come up with the best plan to get rid of that cancer and to get you back on the road of recovery.
Thanks for listening, and please join us again for the Cancer Care Podcast, presented by Arizona Center for Cancer Care. For more information on the highest quality of cancer treatment in Arizona, please go to ArizonaCCC.com.